Hello, on today's episode of Intern Crash Course, I'm discussing how to run a family meeting. While it's not necessarily difficult to run a good family meeting, there are best practices and some non-obvious nuances that will make a successful meeting more likely. This video will go over 6 considerations when organizing and running a family meeting. When is a meeting indicated? Who should attend? Where should it be held? What are the goals? Who should run it? And last, what is the structure of the meeting itself? So first, when is a family meeting potentially indicated? Some common reasons include a serious diagnosis will be disclosed, the current treatment plan is not working, a difficult decision needs to be made regarding the patient's discharge destination. For example, an elderly patient with limited mobility and mild dementia who strongly desires to return to their private home, while the medical team feels like this would be unsafe. There is discordance between either the patient's goals, current treatment, prognosis, or code status. A common situation in this category is a patient with advanced terminal illness who is nearing the end of their life, but who remains full code. And a meeting can be indicated when there is significant interpersonal conflict between the patient, family, and medical team, particularly when that conflict is getting in the way of providing optimal care. The next question is who should attend the meeting? Obviously, the patient if they are able to participate. Other attendees include the patient's surrogate decision maker and the patient's primary caregiver. These are often, but not always, the same individual. Any other family or friends the patient wants present. Of course, we'll want representatives from the primary medical team. That does not mean the entire team needs to be there per se, but if at all possible, the patient's intern should be. Any highly relevant consultants. So if the situation is that a patient is terminally ill from a particular disease and some end-of-life decisions need to be made, for example, turning off an ICD in a patient with advanced heart failure or stopping chemotherapy, it's really nice to have the relevant specialist present. This is usually not logistically possible, but it's great if the patient's primary care physician can attend, particularly for end-of-life discussions. And last, don't forget to include non-physician members of the medical team if relevant to the discussion. So this most obviously includes social workers and case managers if it's a situation involving a complicated discharge plan. But I've had nurses, PTs, and even speech pathologists participate in meetings before. Regarding where the meeting should be held, there are 4 criteria for a good spot. It needs to be accessible to everyone who is participating. It needs to be large enough for everyone to comfortably fit. It needs to be private. And it needs to be reservable. Depending on your facility, your patient, and the number of participants, sometimes you're going to find it's not possible to meet all 4 of these criteria. But you should really do what you can to try to meet them. And when picking a room, avoid one with a single long table, which the medical team lines up on one side and the patient and the family lines up on the other, as that can suggest an adversarial dynamic. What are the goals of the meeting? Well, it will obviously depend on why the meeting is being held. As a general rule, I think the medical team should limit themselves to no more than 2 goals per meeting, and the team should meet just beforehand to agree upon those goals. This pre-meeting is also a good time to confirm who will lead the meeting. Usually, the member of the primary team who has had the most contact with the patient should be the one to run it, as, for example, the intern, if they feel sufficiently comfortable. But other options include the primary team's resident, the hospitalist, the patient's primary care physician if present, or palliative care doctor for end-of-life discussions. So now that everything's been set up, what does the actual meeting look like? It should start with introductions. Introductions of family and friends should include the relationship to the patient, and introductions of the medical team should include each person's role. Next is a discussion of the meeting's goals, both the patient and family's goals, and if they're different, the medical team's goals. In order to make sure everyone is starting the meeting off on the same page, ask the patient or the patient's family to summarize their understanding of the situation at hand. After that summary, I like to commend them by saying something like, "That's a really great summary. I'm pleased that our team has been keeping you up to date and that you've been so engaged in your care here," assuming, of course, that's true. You should then correct significant misconceptions or omissions, if any are present. Now, at this point, don't nitpick terminology. Just correct big picture stuff, like the patient's spouse thinks that chemotherapy has been working well when actually new metastases have been identified. Stuff like that. You want to be sure that the patient and family has an accurate understanding of the situation, but you also want to avoid lecturing them. This is also a good place to provide some positive reinforcement. For example, you could say to the patient's spouse, "It's been really incredible to see how supportive you and your family have been during your wife's illness." Then provide any updates. At this point, before discussing the decisions to be made, ask the patient and/or family, "What questions do you have?" And then comes the actual discussion of the decisions. This is a point when you want to really minimize how much you're talking and should aim to facilitate discussion between the family members. Try to engage everyone present. If one member of the family has been kind of quiet, it may be because that person does not have a strong opinion, or it may be because they are afraid their opinion is not important, or that it will upset the others. But if a person is important enough to be at the meeting in the first place, their opinion is important enough to hear. While not everyone always agrees on the decisions made during a family meeting, everyone should be aware of one another's perspectives. If the patient is not able to participate in the discussion, prompt the family to speculate what they think the patient would say if he or she could. You want the family to be able to distinguish what they want from what they think the patient would want. This will be more challenging for some individuals to do than for others. Don't be afraid to make a recommendation, but ask the patient or family first if they want a recommendation. Some families may get upset if you insert your opinion before they've had a chance to consider the situation themselves. Sometimes a major decision will be made right there during the meeting, and that's great and wonderful, and you should run with that. But sometimes it's deferred, and that's perfectly okay. But if a decision is deferred, try to establish a time frame for making it. For example, "Ms. Smith, I understand a decision about entering hospice is very difficult, and that you might not be prepared to make it right now. Would it be okay if I checked in with you tomorrow afternoon after you've had a chance to think it over and talk with your family?" Along those lines, explicitly lay out next steps, maybe even listing relevant action items for those present. As a general rule, by the end of the meeting, the patient and/or family should have spoken at least as much as the medical team. So that's it for family meetings. While this framework and these pearls aren't complicated, they do take some practice to perfect. But hopefully, you'll now be starting off on the right foot.